Only wants to target. We used to run right over there. Another shame.
All right, for the sake of time, we're going to go ahead and get started. My name is Bradley Brock. Many of you receive very many emails from me, probably more than you care to, but it's just one of those things. Got to make sure I get people here. Today we have Dr. Patel. She is going to be speaking about switch studies, how HIV and viral suppression collaborate together. Dr. Patel works here at UTMB, and she's highly involved with the Ryan White program. She sees patients through the Ryan White program, and she's involved with the Allies in Medicine, many other groups that help with underserved populations and disadvantaged populations, things like that. So without further ado, I'd like to bring Dr. Patel up to discuss what what switch studies are and how it relates to HIV and viral suppression. You're welcome.
Let's see if this works. Okay, is this working? Okay, great. So I'm not, I don't have to stay here, Brad, right? I can move around. Great. So thank you all for being here today. I recognize a lot of familiar faces, which is always great. I wanted to chat today about something that is always been kind of an interest of mine, which is, in HIV, we always have these new medications that come out, and then we have patients that are on much older regimens, and the dilemma is always, well, do we need to do anything about this? And so I wanted to go through a little bit of the data and a couple of cases of when we might want to consider switching regimens, whether it's the entire regimen for a patient, or whether it's just switching out one particular medication for a patient. One day I hope to have some disclosures to make, but I have no disclosures to make. So, and what I'd like to do is think about a couple of the reasons why we might want to switch medications for a multitude of reasons, and then look at some of the studies that inform the switching approaches that we use. And then think about the type of patients that might be good candidates. Sometimes they're very obvious and they come in really with the chief complaint of, I want to switch my meds. And then sometimes they come in with just very subtle, side effects that maybe they've been experiencing for years and they've just learned to live with it. And it isn't until a lot of probing, until you kind of realize that, I think this is more a side effect of the medication. Or you realize that, they never had issues with high cholesterol and now they have issues with high cholesterol because maybe of the medication. And so before you're considering, adding a statin to that patient, you might want to think about, well, should we consider switching that medication altogether? And this is something that is wrought with a lot of anxiety for patients, because once you find something that you're doing well with, you don't want to change. And also the provider, you don't want to change, what isn't broken. So I think it really involves having that conversation with the patient about, is this really working for you? And is there a way of trying to mitigate some of the issues you might be having? And then we'll go through a couple of cases to identify whether patients are appropriate for switching or not, and then if we do want to switch them, what the appropriate switch might be. And a lot of times there isn't necessarily one slam dunk answer. If you ask 5 different HIV doctors, you might get 5 different answers of what you could switch to. And that's because we have so many more options than we used to have. And I also tell patients, you're not married to this. We switch to something and there's a complication, there's an issue. You're not committed to it. And, the caveat here is there are some studies looking at just switching to a 2-drug regimen. I'm not really going to talk about that. There's some studies that are looking at the effective regimens for people that have extensive drug resistance. I'm not really talking about that. The population that I really want to focus on are patients that have had HIV, are doing very, very well. Their CD4s are high. They've been virologically suppressed. Their viral loads are undetectable. I'm talking about that population of patients, because if we talk about all of them, this would be a 6-hour talk, which I don't think anybody wants, including myself. So that's going to be the population of folks that we're going to be chatting about. I do want us to recognize that there's been a lot of change in HIV and that the landscape of HIV is very different, from having PrEP and patients on Truvada to try to prevent HIV acquisition, to the public health campaign of U equals U, of trying to get as many people as possible on HIV medications so that they can prevent the risk of transmission to other folks as well. Anybody know who this is? It does look familiar. This is our famous Berlin patient, the first patient who, up until recently, the only known, quote, cure of HIV, who had a stem cell transplant. And now he has a friend. There's been a second case of a cure. Patients get super excited about this, but I tell them it's kind of like having a zit on your nose and deciding to just chop off your nose. It's not anything that's going to be prime time for most of our patients, but there is a lot of research that's going on in cure research, and that's been re-energized in the past 10 years. When it used to be, let's not waste our time or our money. Now it's actually something that that's being funded, and there's a lot of money going into that. And thinking about cure in different terms, thinking about cure in terms of eradication, but then also thinking about cure in terms of being able to induce someone's body to suppress the virus on their own. So it's not necessarily cured, but it's what we call a functional cure, where you're not having to take medications. And then also a lot of research going into vaccine development as well. So I think there are a lot of things that are changing and are continuing to change. And a part of that is also the landscape of HIV medications. So, the first med that we had was AZT here in 1987, and that's kind of all we had for a while. And I know some of you have patients who were on monotherapy with AZT who can tell you horror stories of what that was like and all the side effects that they had to contend with. And then really throughout the years, we've had more medications, different drug classes, and a proliferation of one pill once a day options as well. So these are kind of some of the one pill once a day options that are currently on the market. And I have kind of both names here because it's really hard otherwise. And the two that are recommended as first-line regimens for patients are Biktarvy here and Triamet Cure. But you can see that these options, we have a huge world of options. So when we see patients on older regimens, we might want to think about whether they would need to be changed. And these are our recommended initial options for treatment-naive patients who have no resistance, and let's pretend they have no comorbidities either. And of these, this one is going to be a fixed combination, a single tab pill, as is this one. So two of the three are going to be kind of as simple as we can make them, one pill once a day. So what would be some reasons why you would want to switch someone's medications? They're doing well from the numbers standpoint. Their CD4 is high, their viral load is suppressed. Why might you want to still think about switching their medications? Adverse effects, okay, good. Wow. Newer pills are smaller, yeah. Especially for those folks that, have a lot of issues with swallowing the pills. Sometimes folks are, cutting them or crushing them when you're not really supposed to. Definitely. Lifestyle. Cost, yeah, cost is another one too. Also, sometimes as patients change insurances, we sometimes have to change because of that as well. That's something we're running into more and more. What are other reasons you might want to change? Right. Hep C treatment is one of those things that if we anticipate that if they have Hep C, usually initially we'll have them on a regimen that we know might be compatible. If they come to us on a regimen that's not, then we might use that as an opportunity to really switch them to something that might be easier. Okay. What else? Hey, what's that? Yeah, definitely if they're not responding, then we would think about them having virologic failure. Maybe they have resistance. Yeah. Some patients, maybe their partner is on a certain medication and they want to be on the same medicine. They want to take it at the same time. They want to, that helps in terms of adherence. It helps in terms of, them being able to support each other. So there's really a multitude of reasons. Definitely side effects, even if they're subtle. Long-term consequences. So as these patients are on these medications for longer and we have better long-term data, we know, for example, tenofovir was kind of the golden child and co-formulated with atripla, and then we started realizing that there are these long-term kidney consequences and bone consequences, and so then wanted to kind of prevent those things in our patients. So started talking to our patients about kind of transitioning off of that. Other comorbid conditions, and we'll go through a case about kidney disease and how that changes the calculus as well. Maximizing adherence as well. So making things as easy as possible. So someone's on a twice-a-day regimen, really trying to make it as simple as possible. Some of these medications, there is a food requirement, and having to remember to take something with food really requires you to have to change your whole schedule and your entire day around when you're going to eat so you can take that medication. Sometimes when patients have a change in lifestyle, say they're switching jobs, they're switching from working days to nights, we'll take that into consideration as well. Obviously being able to minimize their pill burden, if there are drug interactions between that and something else. So I think there are kind of a multitude. Sometimes patients just, they come in because they feel that, they saw a commercial for something and they feel like it's going to work better and it's newer and they want to switch to it. So there are many, many reasons, why you might want to consider it. And we also know that, people with HIV are living longer and longer. So we're going to see folks that are on these stable regimens that may be on kind of older and older regimens. This is kind of the prevalence of HIV in Texas, and it's going to continue to increase as people are living longer and longer. We're also seeing an aging HIV population. So this is the folks that are kind of under 50 years, over 50 years, and as our population of HIV-infected individuals ages, we're going to be seeing more folks that are older in this direction. And what we also know is our patients with HIV are not necessarily the same as the general population. Everything else the same, they tend to have higher rates of comorbidities. They tend to have higher rates of, high blood pressure and smoking and all those kinds of things. So they are a more kind of vulnerable patient population. And even age for age, so this is HIV negative, HIV positive, age for age, this is less than 40, this is over 60, you can see that the folks with HIV tend to have more just number of comorbidities. So we're dealing with an aging population that is also tending to have more comorbidities. So it's not just the HIV we're looking at, we're also looking at their heart disease, their kidney disease, their liver disease, kind of the entire picture. And we know that there is a huge effect of the HIV medications on some of these comorbidities as well. So, protease inhibitors and hyperlipidemia, that's something that, has a very well-established link. We have a lot of patients that have been on protease inhibitors that have a lot of cardiometabolic effects that we're still kind of dealing with. Liver disease as well changes the calculus of what kind of medications we use and the dosing of those medications as well. Almost all of our medications can cause hepatotoxicity to some degree, some more than others. And then for HIV-associated dementia, and then for neuropsychiatric issues, we have some medications that are probably worse than others for that. And then, I had mentioned tenofovir specifically and bone disease as well. So kind of keeping all this in mind. Some things to think about before switching. Obviously we want to make sure that we're reviewing all the relevant information. So we want to know definitely that the patient, what their CD4 is, what their viral load is, but also their previous history of HIV meds. What if they've had virologic failure in the past, if they've had any degree of resistance in the past, because we certainly don't want to switch their regimen to something that's less potent. We never, ever, ever want to do that. And any kind of medication intolerance or side effects that they've had in the past. Any concern for previous resistance, even if their resistance assays are totally normal. So, there are some things that we're going to be able to pick up on our resistance assays. There's some maybe minority variants or archived resistance that we might not be able to. So really kind of methodically going through what their previous regimens have been, and looking at their other conditions, their other medications, and any barriers they might have with the current, with their current regimen or a potentially new regimen as well. And any of those medications that, maybe they don't take all the time, but yeah, every spring I got to take my Flonase all the time. Okay, that's going to change the calculus on some of the medications we're going to give. And you'll be surprised, I think a ton of our patients are on medications that interfere or interact, and we don't always know it because they're not on their standard list of the medications that we give them. So there really isn't a one-size-fits-all approach. It's individualized to the patient and what their needs are. Sometimes I have patients come in and tell me, okay, just tell me what the best one is. And I say, I wish I could, but let me tell you kind of the pros and cons of all of these, and you tell me what you're worried about, and we will work around that. If someone's really worried about side effects, that's one thing. If they're really worried about adherence, if they're really worried about, I really don't think I could take this with food, or whatever it might be, then we kind of work around what their concerns are. And as new medications come out, we're always thinking, is what they're on as good as what's coming out? Is there any benefit to potentially switching? And our goals are going to be always to maintain virologic suppression. We don't ever want to switch someone and realize that we've done, we've switched them to something that they were resistant to, and all of a sudden their viral load increases. We never want to do that. We want to do it in a way that preserves future options for us as well. And we want to try to simplify as much as possible. This is all about, they're going to be on these medications lifelong, so we need to make it as easy and as simple as possible. So it should be improving their life in some way and not making it worse or more onerous for them. And anything we could do to minimize any side effects or drug interactions they might have. And patients have actually, for those that have been on treatment for a long time, some of them have evolved quite, I think, complicated ways of either reminding themselves to take medications or of behaviors around taking their medications that on the outside to me seem really cumbersome. So I always ask how they take their medications and how they remind themselves and how they kind of fit it into their lives. And if they have to go through a super complicated process, and that's something that they've done for a really long time, we kind of dig a little bit into how it's impacting them. If they're happy with their complicated process, okay, and they don't want to change it, that's fine, we can leave it alone. But if they have this complicated process and it's taking time away from other things, if it's putting stress on their relationships, if it's really not serving them well, then we really try to dig into that so we can change or switch it. So let's dig into our cases a little bit here. So we have a 36-year-old male with history of HIV. Last CD4 was 560. Viral load was undetectable. On a tripla, so that's tenofovir, emtricitabine, and efavirenz. Has been on this regimen for 5 years, and let's just pretend that these are just the only regimen that these patients have been on. Also has a history of depression and anxiety, who presents for follow-up. He reports good adherence, states that he's doing well. Sometimes he feels drowsy in the morning. No side effects have been reported by him. Patient's excited because he's going to start working as a nurse. He's going to be doing some shift work consisting of some days, some nights. Would this patient be a candidate for an ART switch? What do you guys think? Yeah. So that's one consideration, that he has anxiety, depression. We don't know how well controlled that is. So there are some folks who, I mean, obviously you need to be very, very cautious with the efavirenz-based regimens and depression and anxiety, because they can make those worse. And there's a big kind of life-changing event that's going on. Okay. Any other thoughts on this? Drowsiness? What about the drowsiness?
Well, doing shift changes and stuff, depending on when you take the meds, it could affect, if he's taking it in the morning, it's causing him to be drowsy, it's probably no good idea.
Yeah, and how do we ask patients to take the AAA? It's very specific how we ask them to take it. Same time every day, and we're very prescriptive about that time, right? At the same time when? It's the same time at night, on an empty stomach, before bed. And that's partly to sleep through some of the side effects of the drowsiness. But also, if they eat a meal with it, particularly a high-fat meal, that really ramps up the area under the curve for the absorption, and it increases the concentration in the blood, and it increases the side effects. And so it looks like if he's going to be switching days, nights, this is going to be really tough for him. And I also tell patients not to take it and operate heavy machinery or drive. They take it and go to bed. So this is somebody that I think maybe has multiple reasons that we might want to switch. Especially, I think if he wasn't having this new job, I would want to inquire about how his anxiety and depression has been. And if they're uncontrolled, even consider it for that. But definitely with his new work schedule. So there was also a lot of data that patients with underlying psych issues, especially depression, are more likely to discontinue efavirenz-based regimens because of worsening. About 30% of patients have some sort of neuropsychiatric symptoms. The fixed dose pills are usually associated with lower side effects than the ones that are separate. But there are genetic polymorphisms that we all have that allow the efavirenz component to linger a little bit longer than other medications. So there's also another formulation where the dose of the efavirenz is lower as well. So this would definitely be someone we would think about. So we think we want to change him, okay? What are we going to change him to? So these are our options. There's Simtuza, which is darunavir boosted with cobicistat, TAF and emtricitabine. Complera, which is rilpivirine, tenofovir, and emtricitabine. Valtegravir epsicom, which is abacavir, lamivudine. Maraviroc with epsicom, which is abacavir and lamivudine. And if your choice isn't on there, I just wanted to be mean. So what do you guys think? Okay. So you don't want to affect his depression. what else? He's going from a 1 pill once a day. Do you want to go from a 1 pill once a day to a 2 pill once a day? Okay. So then maybe this one is out. And then this wouldn't even be an option. This would be for patients that have resistance. So we could get rid of C and D. What do you guys think about A and B? So here we have a PI-based regimen, and here we have a kind of second generation NNRTI-based regimen. Okay. Okay, that's a logistical issue. So really both of these are defensible, let's say it that way. Both of these could be defensible. Probably ones that are not on there are better. But I didn't want, the answer to be the same for all of these. So just for the purpose of being able to review some of these switch studies, there were some studies looking at switching efavirenz to rilpivirine and keeping the rest the same. So this is an example of where you're switching just really that one component. So you're switching from the efavirenz to the rilpivirine. So rilpivirine also has some CNS effects, but it's not as much as the efavirenz. And what they noted here is in terms of virologic suppression, that there was non-inferiority. So it was pretty much the same. In terms of CNS discontinuation and side effects, the rilpivirine was better when compared to the efavirenz. So this is an example of just a single switch where you're like, it's really that efavirenz component that's causing this, and I want to just switch that one out. This isn't to say that this is slam dunk what you would do in this situation. This is an option of what you could potentially do. We have even newer medications that might be more ideal. So there are different strategies depending on whether you're switching within the same class of medication versus between classes. So here it's same class, though this is a class where you're switching between agents that have similar barriers to resistance. So efavirenz, rilpivirine, very similar. The exception to this would be doing something like dolutegravir, and then switching from that to something like valtegravir or elbapixvir. With that situation, you really need to make sure that there's no NRTI-based resistance, because you never really want to go to a less potent regimen and risk losing virologic suppression. So you really need to make sure if you're going to do that, that there's really no concern for resistance at all. And this is when you're doing between classes. So you're kind of, you're not just going to switch one little agent in one class, but you're switching from one class to a different class of antiretroviral therapy altogether. And so if you're switching from a boosted, boosted PI with ritonavir or with cobicistat to dolutegravir, that's fine because they both have super high genetic barriers to resistance. So I know I keep using genetic barriers to resistance. I just want to pause. Does everybody feel comfortable with that term? Because I can back up let me back up a little. So different antiretroviral drugs have different what we call genetic barrier to resistance. And what that means is what the likelihood of developing resistance is. So usually, back in the day, boosted PIs had a very high genetic barrier to resistance, meaning that, say someone didn't always take the medication 100% of the time. Chances are it would take a really, 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 really long time for them to really develop resistance. That they might have an elevated viral load, but they were unlikely to develop resistance that quickly. It takes much longer time. There's some medications, so some NRTIs and then an NRTIs that develop resistance more quickly. So we say they have lower genetic barrier to resistance. And some medications, you have just one, the virus adapts and develops one mutation, and you're done. You can't use that medication anymore. It's not going to work. So this is kind of where we talk about genetic barrier to resistance. So boosted PIs and dolutegravir have very high rates of the genetic barrier to resistance. They're pretty comparable. And throughout the years, I finally come to believe this. Though Dr. Kaiser told me this was the case a very long time ago, but I only now believe him. But if you're switching from a boosted PI to an NRTI or to these integrase inhibitors that have a lower genetic barrier to resistance, you really need to make sure that there's no NRTI resistance that's there. So here is our second case, 54-year-old male with history of HIV, last CD4 360, viral load less undetectable, on darunavir, ritonavir, tenofovir, and emtricitabine for 3 years. Hypertension CKD, presents for follow-up. He reports good adherence, states he's doing well. You get blood work and realize that his eGFR is 40. That's not new. That's just what it's been. That's what its CKD has been. Would this patient be a candidate for an ART switch? What do you guys think? Maybe something that's easier on the kidneys. What is he on that's not so, that the kidneys are probably not happy about? The tenofovir can be nephrotoxic. You can still use tenofovir with some degrees of chronic kidney disease, but it needs to be renally dosed, and then there's an absolute cutoff. For these fixed dose combinations, you usually have to separate them. So say you're going to switch them. What do you switch him to? You switch him to a tripla, which is tenofovir, emtricitabine, evaporins, Triamec, which is abacavir, emtricitabine, dolutegravir, valtegravir, and Truvada, which is tenofovir, emtricitabine, Biktarvy, which is bictegravir, emtricitabine, and tau. What do you guys think? Triamec or Biktarvy? So you just don't want anything with tenofovir. Okay. Anybody else want to weigh in? I would definitely agree. We would take out anything with the tenofovir component here and here. What would we want to know about, if we wanted to give him this, what would we want to know about him? What tests would we want to order that we don't have? The HLA with 701. And is this one safe to use for kidney disease? How many of us say yes? How many of us say no? How many of you say, just tell us? Okay. Yeah, okay. This is basically the creatinine clearance with which you can use tenofovir, and this isn't Truvada, this is just the tenofovir component. And look at the dosing, though. This is, for creatinine clearance of 30 to 49, you have to take this through 48 hours. Have any of you taken medications like this? It is impossible to remember to take something every other day or every third day. So it gets really complicated. 10 to 29, twice a week. And then if you're on dialysis or less than 10, if it's less than 10 and not on dialysis, they basically say not to do it. On dialysis, it's once a week. For the Truvada component, because it's fixed dose, you can do it Q48 hours for creatinine clearance of 30 to 49, and it's not recommended if you're less than 30 or on dialysis. So this is the official recommendation. So for the triplet, it's not recommended, and this is mainly because these are fixed dose. They really want you to, and you'll see this for patients with chronic kidney disease. Sometimes they're on these kind of complicated regimens because they're all of their meds are split apart. So this is not recommended for creatinine clearance less than 50. They ask that you tease out the individual components. Triamec, same thing, and this is more for the FTC component. And raltegravir, actually there's no renal dosing needed for raltegravir. This is mainly for the Truvada component. And Biktarvy, you can use it until the creatinine clearance is less than 30. So technically, the answer was Biktarvy because their creatinine clearance was 40. But you could do the Triamec, but you would have had to do the back of your all of these separate, which increases the pill burden. And then this was a trial. They couldn't think of a cutesy name like a lot of the other trials, so they just called it Trial 1878. And what they did is they enrolled patients that were on boosted PI-based regimens, like our patient was, and they separated them into those that half of them switched to Biktarvy, and then half of them just continued their normal regimen. And then at 48 weeks, they looked to see if they were virologically suppressed. And 92% of the patients that they switched to Biktarvy were suppressed, and 89% of these folks were suppressed. So basically showed that, it's effective to be able to switch them. And these are all folks that had high CD4s and were virologically suppressed to begin with. So you can go from boosted PI to Biktarvy. This is case 3. There's only, I think, one left after this. There's a 37-year-old female with history of HIV. Last CD4 was 1,200 with a suppressed viral load. She's on rilpivirine, tenofovir, and emtricitabine, which is Complera, for the past 10 years. I hope the math works out on that. She presents for follow-up. She reports good adherence and is doing really well. However, her partner is on Triamec, which is dolutegravir, bacavir, and lamivudine, but she wants to switch to the same medication. She also states that it's really difficult for her to remember to take the Complera with food. Would this patient be a candidate for a switch? You're like, why do you have to do it? Well, she's also having the issue with remembering to take it with the meal. So she is having a little bit of difficulty with that. So, she's doing very well on it. And to make things easier for everybody, let's just say, to keep the idea of pregnancy out of this, that she's had a tubal ligation, so we don't have to worry about that on top of everything. Take it with her. So you might think about switching her to something else, okay? And there may be a difference between, with the Complera, she has to take it with food. With the Triamec, you can take it with or without food, and it's true that a lot of our patients say, when I take it without, I do get this GI upset, so they end up taking it with food. But it's not a requirement that you have to take it with food. But would we be okay with this? There's a no? No? Okay. Okay. Is there anybody that's like, you know what, I'm fine with this. Let's go ahead and change her. Mm-hmm. This is pretty much a complete switch, right? You're not just switching one component. You're switching pretty much everything. The emtricitabine and lamivudine are pretty much interchangeable. Definitely tenofovir and the bacavir are different. And she's going from a totally different class, from a second generation NNRTI to an integrase inhibitor. So we're changing it all up here. Okay, so some people would convince her to stay on it. How many of you would say, okay, let's try to convince her to stay on it? Okay, how many of you would be like, no, whatevs. she could get on this new one if she wants. Okay, so let's see what happens. There actually was a study looking at switching people on various regimens, including the one that she's on, that were virologically suppressed with high CD4s, that continued on the current regimen or were switched to Triamec. There are about like 500 something patients in all, and they showed very similar rates of virologic suppression. I know technically these numbers look a little bit different, but they're basically, when you do the statistics, are pretty much the same. So as a switch strategy, you could do it, but we're gonna see one that goes wrong here. So this is a 24-year-old male to female transgender patient with history of HIV, last CD4 is 390, viral load is suppressed, on a boosted PI-based regimen, darunavir, ritonavir, abacavir, lamivudine, for 3 years, presents for follow-up. She reports really good adherence. However, her partner is on Stribilz, which is elvitekravir, cobicistat, tenofovir, and emtricitabine, and she wants to simplify her regimen to the same one pill once a day. Would this patient be a candidate for an ART switch? What do you guys think? Possibly? What makes you say that? Mm-hmm. Okay. Yeah. So basically, the 3TC and the FTC is interchangeable, but then you are switching these two, and you're going from something with a very high genetic barrier of resistance to something with a lower genetic barrier of resistance. But this is one pill, and this is 2 pills. So you're at least decreasing her pill burden, maybe. So what do you guys think? Mhm. Mhm. That's a big one. Mhm. Okay, so it turns out you don't do any of that, and you switch her. And she gets switched to Stribilz, and then she develops virologic rebound with a viral load of 1,000 within a month after being undetectable for 3 years. What are the possible explanations? One is what you just said, is drug interactions. What are other possible explanations? And I'll go back to her regimen so you guys can see what she was on and what she switched to. Yeah. So she already had some resistance there, and then when you switched her to a lower potency regimen, you selected for it. So that's exactly what ended up happening. Is you got her records from outside hospital from 5 years ago, and it showed her initial resistance assay had what we call transmitted drug resistance, because about 10 to 15% of people who get infected with HIV get infected with a strain that's already resistant to one of our meds. And she had the M184V, which confers resistance to FTC or 3TC or emtricitabine or lamivudine, and the K65R, which confers resistance to tenofovir. When you're on a super high potency regimen like the boosted PI, sometimes we can still get patients to suppress because it's so potent. But then once you put them on a lower potency, we start noticing those NRTI mutations come up. So this is one of the reasons why it's important to consider, going from higher to lower genetic barrier resistance regimens. So these are some switches to avoid and never ever ever do, because all of these have been associated with virologic failure. So boosted PIs or integrase inhibitor monotherapy, there were some studies looking out at, maybe we can just spare everyone from these horrible NRTIs, which now actually have a better side effect profile than they used to. And they were just had unacceptably high rates of virologic failure. Dolutegravir monotherapy, also high rates of virologic failure. The combination of boosted atazanavir with valtegravir, nobody really knows how or why, but that combination, the virus just really thrives and has a lot of viral rebound with that. Maraviroc in combination with raltegravir or a boosted PI. And this Maraviroc is the CCR5 antagonist. We really reserve that for extremely treatment-experienced patients that have failed multiple treatments, multiple regimens. So you're not going to see a lot of folks on that. And because we can't really use it with boosted PIs or raltegravir, once we get to that, we don't have a ton of options of what we can use it with. So my take home is really to think about ART switches in patients for improvements in adherence, side effect profiles. We have a lot of folks that have been on ARRL forever, and when you talk to them, they're like, yeah, I'm doing really well with it, but I've had insomnia for 5 years. And we switch them, and all of a sudden, that gets better. So there's sometimes really subtle effects, and I feel like it's more with ARRL than a lot of other things that you really need to ask about. And also, now that we know more about the long-term effects of really trying to be proactive about before they develop kidney disease, trying to get them off of that tenofovir component. And now we have the milder version, which is TAF, that we're trying to get folks onto as well. The thing that we really, really, really need to hammer is to make sure that they have continued virologic suppression. We really don't want to make anything worse for the patient. And then when switching, to really think through their previous regimens, previous resistant panels, and all their comorbidities as well. So that's all that I have. The DHHS guidelines, which get updated every year, sometimes multiple times a year, have an entire section on switch strategies and how to switch, and for anybody that's interested, that's a really good section to read. There are studies that come out literally on a daily basis about how to switch from one medication to another medication. So I'm happy to take any questions with the last couple of minutes that we have. Well, thank you guys so much. I really appreciate it.